Good morning and welcome. I'm Dr. Ashley Bowman from the University of South Alabama. I'm also an acute care pediatric nurse practitioner practicing in the pediatric emergency department at USA Health Children's and Women's Hospital.
My name is Claire Kranz, and I'm also an assistant professor. I work at Auburn School of Nursing, and I'm an acute care peds nurse practitioner as well. I do have a faculty practice, however, it is in the state of Utah as the Evidence-Based Practice Quality Improvement Specialist for Primary Children's Hospital. And we're really excited to be here with you guys today to talk about community-driven asthma care, education, and advocacy in the pediatric population. Before getting started, I would like just to share with you guys that we have no disclosures. Our objectives today are here. We're going to discuss different topics within the pediatric population and asthma care. We'll describe the epidemiology of pediatric asthma in Alabama, implement an evidence-based practice asthma action plan in conjunction with asthma control tests to achieve optimal control of asthmatic symptoms in children with asthma. We'll move then into identifying the role of school-specific and environmental triggers for children with asthma, and we'll end with locating applicable school-based asthma healthcare policy initiatives and apply healthcare policy to future advocacy actions. Asthma is the most common chronic condition among children, and it's particularly prevalent here in the state of Alabama. In the United States, 7% of children are living with asthma, and in Alabama, that number is just above 13%. Asthma is also the leading cause of childhood emergency department visits, hospitalizations, and missed school days. And nearly half of all children living with asthma report experiencing one or more asthma attacks in the past calendar year, and that rate is even higher with our Black or African American children. Another risk factor here are those that live in poverty, which we'll discuss here in just a little bit. We see the highest rate of asthma occurring in the young teen population, which will be in our about 12 to 14-year-old age group. And according to the recent census data, about 30% of Alabama's population is African American or Black, and 30% of our children are also African American. Just shy of 16% of Alabamians live in poverty. When we look at social determinants of health, it's very important to acknowledge that the highest burden of asthma is seen in our Black, Hispanic, and Indigenous individuals, and I feel like this graphic nicely highlights that impact. Statistics show that individuals who are Black are 5 times more likely to require urgent or emergent services and are 3 times more likely to die from asthma-related issues. Air quality and pollution also play a very important role when we talk about asthma and that impact here for Alabama. Approximately 10% of all asthma-related emergency department visits are secondary to poor air quality, and that includes a number of different factors. Elevated particulate matter and pollen severity are also associated with poorer asthma control in general, and personally, I felt the asthma severity this spring. In 2020, the State of the Air report showed that the Jefferson County, Talladega, and Hoover County, that combined area, ranked 14th nationally for pollutant exposure annually, and that measures the cumulative exposure over one calendar year. So that's a significant impact that we see here in the state of Alabama. The 2021 results just were published this past month, and we saw some improvement, but our vulnerable populations still remain at risk. For millions of people in the United States living with asthma and other chronic illnesses, exposure to air pollution places them at a greater risk of harm to their health than those without disease. The cellular injury and systemic inflammation triggered by breathing ozone and particulate pollution put additional stress on our lungs, our heart, and other organs that are already compromised by disease. And it can result in worsening symptoms, increased medication use, and more frequent emergent visits, and even hospitalization. Unfortunately, it also can lead to premature death. When we look at our social determinants of health related to air quality, it's important to note that people of color are 3 times more likely to be breathing the most polluted air than their white counterparts. And we see that both individuals that are Black and brown and those that are living in poor communities tend to be exposed to those environmental triggers. Air quality is measured in terms of ozone and particulate matter, among other things, but we'll kind of focus on those here for just a second. In 2018, research found that low levels of ozone outdoor are associated with respiratory changes, and specifically we found that it decreased our lung function for children of color, and most of those ended up with moderate to severe asthma. And the finding was despite the fact that those individuals were routinely using inhalers and quite compliant to their asthma therapies. Again, the Jefferson, Hoover, Talladega County area has a very high level of ozone as measured by the National Ambient Air Quality Standard. So it's something that we are seeing here in the state of Alabama. When we look at particulate matter, exposure in children is associated with increased asthma-related ER visits and hospital admissions. It also increases the likelihood of cardiovascular and respiratory disease, and we see that children 11 years and younger are more likely to have these issues. We also see those that are living near roadways. So like if your homes are situated near a roadway, they're more likely to be exposed to the brake and tire particles, road dust, and metals. So even though our housing communities that we often situate near roadways improve access to public transit, we also find that the individuals that are living in those communities are exposed to these poorer air qualities. And children with asthma that are exposed to outdoor ozone and or the particulate matter have a higher rate of school absenteeism than those that aren't living in those situations.
So now I want to talk to you a little bit more about asthma and how it relates to other factors that of children's day-to-day lives. We're here to talk to you today about community-driven asthma care, and I know Claire and I both feel very passionately that asthma is really managed within the community and day-to-day. It is really something that is focused on prevention rather than reacting to those acute and emergent visits that I see so often in the emergency department. Children spend most of their day at school, so this is really where we can focus a lot of our asthma interventions. Asthma-related school absenteeism can result from asthma exacerbations, lack of control, or just due to not seeking routine asthma care, meaning that they're seeking out either an asthma specialist or their primary care provider to get their routine meds and maintain their asthma control. We know that 13 million days are lost in school annually just because of asthma. And that not only accounts for the school day loss, but also the work hours lost for parents taking care of sick children. School-based asthma triggers are vital to ultimate control of asthma. We know that children spend most of their day in school, and so it's really important that we focus our effort and prevention at reducing school-based triggers since children are spending most of their waking hours there. Triggers in school may include cockroaches, pests, mold, classroom pets, pet dander on the clothing of other children in the classroom, not necessarily the child with asthma, secondhand smoke, dust mites, cleaning products, exhaust from buses, and outdoor pollution. And we'll talk a little bit more about what we can do for those triggers and what policy initiatives we can implement to help focus on those triggers a little bit later. Children with asthma in school can perform well if their asthma is well controlled and the school is deemed quote unquote asthma friendly, which again we'll talk about a little bit later what that means. So asthma and COVID-19, I would be remiss if I didn't mention the changes that the pandemic has brought to us over the last year plus in the world of taking care of patients with asthma. Our entire way of really managing asthma has changed in really the shift of how we have had to adapt because of COVID. We're definitely seeing virtual visits across the board, and so that does impact our patients with asthma. A survey of clinics worldwide found that there really is no increase in incidence of COVID among children with asthma, so that's very reassuring that children with asthma are not suffering more from COVID. There's been a drastic change to asthma management, meaning that 39% stopped offering physical appointments and 47% of providers stopped taking new patients. But asthma control did increase by 20%. So there are some reassurances coming from COVID-19 because patients are more driven to adhere to their regimens. And then there's been a decreased exposure of triggers, and that really accounts for the change of environment, the shift to some virtual learning, decreased exposures to viruses, allergens, and pollution due to social distancing and also from not attending school. Similar results from a retrospective analysis by Children's Hospital of Philadelphia, was used to compare historical trends to outcome measures during the first 60 days of the stay-at-home orders back in March of 2020. And they found that there was an 87% decrease in the daily number of outpatient encounters and an 84% decrease in hospital encounters. However, telephone visits increased by 19%. Once telemedicine visits were widely available, they accounted for 61% of encounters for asthma care in March of 2020. There was also significant decreases in rhinovirus, a known virus to cause the common cold. So how does that all relate to asthma, COVID-19, and the school? So I think that this graphical illustration of our flu rates over the last several flu seasons really illustrates all that we have seen with COVID-19 and the repercussions of all of the measures we've put in place to prevent the spread of COVID-19. We have seen such a drastic drop in flu rates to a historic low this year, as you can see in this graph. And really there's been this shift from virtual to from in-person to virtual learning, and how that has impacted our children. Children with asthma have not been shown to have an increased risk for morbidity or mortality related to COVID-19, as I said previously. But interestingly, the CDC does report that asthma is the most frequent chronic condition affecting school-age children with lab-confirmed COVID-19. So there still are patients with asthma contracting COVID-19. However, it has not increased their risk of morbidity and mortality. These same patterns were seen back in the SARS outbreak of 2003, which was correlated again to improved hygienic measures, meaning the masking and social distancing. Abrams et al. In 2021 outlined the risk and benefits of in-person versus online learning. Benefits of in-person learning include improvements in school performance. This was particularly noted by patients who experienced negative outcomes related to social determinants of health. So those very same things that Claire was pointing out in the state of Alabama, with our poverty rates and also with our African American population, we have to really worry that they are suffering more from not being able to take part in in-person learning. School-based medical programs are also available to those participating in person. So there's concern that students who are participating virtually may not be able to get their routine asthma care if they are using something like a school-based health center. Virtual learning offers a generalized lower risk of infection from those common viruses that we've named previously. The authors concluded that diagnosis of asthma alone should not preclude in-person school attendance. Additionally, there is a reduction in general illness among children who have previous wheezing, which has been attributed again to things like social distancing, virtual learning, and masking. Actual versus perceived risks should be discussed with parents and schools using that data that we now know with COVID-19 and the subsequent measures that we've implemented. The Canadian Thoracic Society position statement offered a similar support for return to in-person learning for children with asthma on the premise of stronger benefits related to the risk potential. The evidence today has supported only rare cases of morbidity from COVID-19, and most children have mild disease or are asymptomatic. There are negative consequences to not attending school in person, including delayed care for many conditions. The Canadian Thoracic Society additionally supports hygienic measures to control the spread of COVID-19, like social distancing and masking. Face masks do not worsen asthma symptoms, but rather difficulty breathing while wearing a mask may be a sign of poor asthma control. It is vital to maintain good asthma control, including regular use of controller medications as prescribed. Interestingly, they cite data to show that inhaled corticosteroids may have even a protective role in contracting COVID-19, meaning that if they are adherent to their daily controller, that they actually are protected more from contracting COVID-19. Schools are vital to the regular maintenance and control of asthma in school-age children. There is a need to ensure that these children are being regularly seen and focused attempts to address school-based triggers, which we will discuss a little bit more into the presentation.
Asthma action plans and asthma control tests are great ways in order to ensure that our pediatric patients are having very well control of their asthma. The Asthma Action Plan specifically is an evidence-based tool that, if utilized appropriately, can help decrease the number of missed school days, emergency room visits, and hospitalization. An Asthma Action Plan is a personalized education tool. It is used to outline the asthma care of each pediatric patient and the symptoms that they're having, with a clear plan forward of what to do and how to do those things in different situations, primarily based on symptoms and, again, based on their asthma control. Yet we see that less than half of children diagnosed with asthma in the United States have ever received a written asthma action plan. And only about 34% of all providers say that they use them for each of their patients. Oftentimes, asthma action plans are written and put into the electronic health record, but they're not actually provided to the patient, the family, or the schools. And so that's a big barrier that we need to overcome. Asthma control tests are used in conjunction with the Asthma Action Plan for patients to routinely self-identify how well or poorly their asthma is controlled. A score of greater than 19 identifies that your asthma is well under controlled, and there's different tests based on age. The control test should be performed prior to each visit with the pediatrician or primary care provider in order to alter or update that care plan so that the provider and the team in the clinic can determine whether or not the asthma medications and the daily plan needs to be updated versus whether or not education needs to occur, or both. It can give a lot of information to the provider team. The Asthma Action Plan should be discussed and provided to every patient and their family, as well as communicated out to the schools and other community locations. The one here on the screen is developed through the Asthma and Allergy Center here in Alabama, which I like it quite a bit because on the front it shows what that written asthma action plan is, which can be specific for each pediatric patient. And on the second page or on the back, it has the asthma control test where we need our patients to be able to self-test. So it's kind of nice to have it all in one place. It's recommended that each student have an individual asthma action plan at school because this allows the school nurse, the teacher, and other school staff to effectively care for the child with asthma. The asthma action plan can and often serves as a provider's authorization to administer medication. So if a child is having an issue in the school, then having that written asthma action plan filed at school allows medications or therapy treatment to occur. 86% of schools surveyed in the CDC School Health Policies and Practices study show that they have a policy that would allow schools to utilize the asthma action plan that's kept on file. A safety net for children at school requires that training and education of all school staff who may come in contact with a child. They need to be trained on how to care for that child who has asthma. And this may include not only the school nurse, but also teachers, PE coaches, food service staff, bus drivers, and many other individuals. Guidelines are also recommended that education for students who may come in contact with a child that has asthma, that they're also educated on things that they can do. And that would really help and aid as they are able to care for their peers who may have an issue while they're playing together, they're learning alongside one another. The American Lung Association has readily available trainings for schools, and they're tailored to each type of staff member who may care for that child in case of an emergency, and they also house training for students as well. So it's a great resource to utilize. The CDC school health policies and practices studies revealed that only 56% of schools surveyed provide funding or offer professional development on asthma, including recognition of triggers, to PE teachers. Yet our PE teachers are often those that are present in situations when children are exposed to asthma triggers, such as physical activity and poor air quality. So that's a place that we definitely need to work on. 75% of schools surveyed offer funding or some type of training for other teachers and staff members so that they can be educated on asthma management, including emergency response. Another option or program that's available to help schools and those to be educated on how to care for pediatric patients with asthma is the CDC's Exhale program. And this is in addition to the American Lung Association asthma training that we just previously mentioned. The Exhale program is an evidence-based strategy bundle to improve asthma control. So using these 6 Exhale strategies together in a community can have the greatest impact for our pediatric patients. These recommendations are geared towards healthcare professionals, public health officers, school, and many other individuals. So I'm going to step through these 6 components here quickly. The first is education on asthma self-management, and this is self-care education and information such as medications, triggers, and asthma action plan. And this begins with the patient and their family, and then from there can expand into the community. Next is extinguishing smoking and exposure to secondhand smoke. It is well documented that smoking and secondhand smoke is one of the major triggers for patients with asthma. Home visits for trigger reduction and asthma self-management education can often be coordinated through local health departments, but we've also seen that schools, particularly school counselors and school nurses, can identify children that are in need of these services and can help coordinate that service through the health department or through the pediatrician. Achievement of guideline-based medication management focuses on adherence to medication plans as prescribed, and this also links with those asthma action plans, making sure that education and that coordination is present. Linkages and coordination of care truly highlights the importance of clear and frequent communication between healthcare providers, our community and school workers, and then our children and their families. And then lastly, our environmental policies and best practices to reduce indoor and outdoor asthma triggers. We've talked a bit about outdoor triggers today, but those the air quality of our indoor locations are also important. That's also seen in our schools to ensure that we have adequate indoor air filtration in our school systems. Exercise is essential to the health and well-being of children with asthma, but it's also essential that PE coaches are able to manage our exercise-induced symptoms of asthma as per the child's asthma action plan and modify activity or those experiences on days where the air quality is poor. So the PE coach can offer either activity modifications or alternatives. And one way that this has been accomplished is the use of air quality flags, which we'll talk about here shortly, or both, asthma pass. And so this standing school excuse allows children to provide notifications of poor air quality or allow students that have exercise specific triggers to stay indoors on days where the air quality is poor. So the purpose of the asthma pass is to identify the children who are at risk for having a trigger or having an issue when outdoor air quality is poor. So on days where the air quality is orange or higher, red, purple, that they can flag the pass and allow the child to stay inside the gym or go to the library on the days that this occurs. And these asthma passes can be given to the school system and like a packet and the same information or the same time as which the asthma action plan is communicated with the school.
So we've talked a little bit about the epidemiology of asthma, both in the U.S. and also here at home in Alabama, and how it's affecting our children and those specific social determinants of health that place them at higher risk here. We then talked about education and how important it is to provide specific education within the community and not relying solely on acute care and emergent visits. So and to tie that all back together, I want to close with talking about policy and how we can advocate for children in Alabama with specific policy actions and initiatives that really are focused on the schools. As pediatric providers, as school nurses, and as public health officials, this is really vital to ensuring our optimal asthma outcomes for children in Alabama. So comprehensive asthma school policies are endorsed by the Centers for Disease Control and Prevention, the American Lung Association, the American Academy of Allergy, Asthma, and Immunology, as well as the National Association of School Nurses. These policies address specific parameters aimed at achieving optimal asthma outcomes, such as in an individualized asthma action plan for each student, the same asthma action plan that Claire was going over with us a little bit earlier, is specifically endorsed within these policies and should be provided to the school. Employing registered nurses at every school, encouraging physical exercise, as well as making allowances for days when full outside exercise is not possible, addressing indoor and outdoor air quality, and stock bronchodilator policies. Additionally, as of December 2020, the School-Based Allergies and Asthma Management Program Act was passed, which gives preference for federal grants to states that adopt specific asthma health policies. These policies are synergistic with those recommended by the aforementioned professional organizations and federal organizations and include things like identifying students with asthma, individualized asthma action plans, nurses on school campuses, education for school staff, and reduction of triggers. So specifically, one of the policies entails the IAQ tools for schools. This encompasses several aspects of the school and the school environment and reducing those school-based triggers that we talked about earlier. The first component is a quality HVAC system. This includes regular inspection and maintenance and things like changing the filter and cleaning the system so that it does not contribute to poor asthma control. Mold and moisture control, regular moisture inspections, a mold prevention plan, and indoor humidity should ideally be between 30 and 60%. And addressing moisture problems promptly. And we all know that this can be a really large issue in the state of Alabama. Integrated pest management, pest inspections with an established plan for how they're going to do that, and communication about the use of pesticides in the schools, because remember that for those with sensitive airways, pesticides can certainly be a trigger. Cleaning and maintenance. There should be routine inspections and a plan. Cleaning protocols with the MSDS or material safety data sheet available. And specific practices like removing dust with a damp cloth and vacuum with high efficiency filters. Cleaning material selection includes low-emitting products, again for those with sensitive airways. They should be formaldehyde-free, and the least toxic cleaner available should be used. And then we should use aggressive source control of offending allergens, which includes, again, just regular inspections with a plan, testing for radon. What are we going to do with hazardous materials? How are we going to store them, and what's the disposal plan? And then a bus idling policy for buses that are idling and creating another trigger. And then a smoke-free campus. So Claire mentioned the air quality flag program, which I have a picture of here. And you can learn more about the air quality program from the Environmental Protection Agency at airnow.gov. But essentially these flags are there to notify the school and the community about the air quality every day. And you can see that green would be a good day, moderate would be yellow, and then orange, red, and purple all indicate unhealthy air quality days. And there are specific parameters that the EPA outlines of what should be done depending on which flag is flying in that day. In order for a school to participate in the air quality program, they will need to purchase the flags, usually about $100 for 5 flags, but again, preferential treatment is being given for federal grants that are addressing some of these very same things. Educating the school and the community about the program. There are sample parent letters and emails for school employees all on airnow.gov. These will tell parents what the air quality program is, and so they understand why that flag is flying for the day. There are daily emails that will inform you of the air quality and also let the school know which flag to fly. As I said before, there are modified activity guides based upon the air flag flying that are available to assist the school staff in finding alternative activities for students who have asthma and could be triggered by this outdoor air pollution. Green flags indicating it is safe to be outside, but yellow flags indicate that students who are unusually sensitive to air pollution could have symptoms, which does include children with asthma. Orange indicates an increased risk for sensitive groups, and it is recommended to have the quick relief medication handy if students are outside for activity. And the red flag indicates that air quality is unhealthy. It is recommended to move long, intense activity indoors or rescheduling for students with asthma. They should also have their quick relief medication available. And last, purple flag means very unhealthy air quality, and it is recommended to move all activity indoor or reschedule to another day. So I want to talk a little bit more about stop bronchodilators and how those play into school-specific policies that we can use to help prevent asthma exacerbations and also manage those that do occur at school. Stop bronchodilator legislation or guidelines allow for emergency use of a stop bronchodilator while at school. While all 50 states do allow students to self-carry their emergency medication, it is quite possible that the student may not have their medication or the medication is ultimately empty or expired. Stop bronchodilator legislation sets forth a specific set of policies and stipulations under which a school stop bronchodilator could be administered by the school nurse or other qualified staff. Stop bronchodilator policies in other states have yielded positive results. One study in Missouri demonstrated that up to 92% of students could return to class following stop bronchodilator administration. And an Arizona school district reduced EMS transports by 40%, ultimately averting healthcare costs directly and indirectly through those missed school days. Stop bronchodilator legislation currently exists in 12 states: Arizona, Arkansas, Colorado, Georgia, recently Illinois, Indiana, Missouri, New Hampshire, New Jersey, New Mexico, Ohio, and Utah. 2 additional states have stop bronchodilator guidelines, and those would be New York and Nebraska. O'Rourke described their path to success in passing the stop bronchodilator legislation in Illinois recently, and their approach used an existing stock epinephrine policy that they then used as the framework for their stop bronchodilator legislation. The Alabama Asthma Coalition, which Claire and I are both a part of, is the most obvious advocacy venue to accomplish stop bronchodilator legislation in Alabama. We have a multidisciplinary consortium of physicians, nurse practitioners, school nurses, respiratory therapists, social workers, and many others who are all collaborating together to improve asthma outcomes in Alabama. However, it will still take the support of everyone to ultimately make stop bronchodilator legislation a reality. The Illinois model consisted of an advisory group that included school representatives to ensure the end result was ultimately a proper fit for them. This group then issued an issue brief, or a summary of their findings, to summarize the state of asthma care in Illinois and the current policy solution for those who might have been less familiar with the topic. So as we close, we do have some resources for schools. We've mentioned a lot of things throughout the presentation that involve schools and specifically endorsed programs through the CDC, through the National Association of School Nurses, and also from the American Lung Association. And so I've provided just a selection of the most the ones we felt were the most helpful resources for schools. And this presentation does include hyperlinks to all of these programs listed here. And we welcome any questions. Please feel free to contact us via email. Again, I'm Dr. Ashley Bowman, and I can be reached by email at F as in Frank, ICARINO @southalabama.edu. And we have also provided a list of references here to, again, help assist us in our journey to further asthma outcomes for children in Alabama.